Uh, Good morning. Welcome to today's session on critical appraisal. So today we'll have a different topic. We have been seeing randomized controlled trials, observational studies in the last few weeks. So today we'll be doing a critical appraisal of a decision analysis. And we'll be looking at a study, looking at an economic evaluation using a decision analysis model. And we have Dr. Anuka who will be doing the critical appraisal. And I hand over to Dr. Anuka, and we'll be open to discussion once the presentation is over. And please feel free to put your questions through chat box, or you may unmute yourself at the end of the presentation to ask your questions as well. I'll hand over to Dr. Anuka for the same. Thank you, Dr. Anuka.
Good morning. Thank you, sir. So today we will be looking at critical appraisal using a new method called a decision analysis. The outline of my talk would be some basic concepts, the tools which we can use, decision tree and the Markov model, what is the process in doing a decision analysis, and we'll look at critical appraisal after that. We will be using decision analysis to do a economic model evaluation. So when you look at economic evaluation, we can do either a study base or you can do a decision analytic model base, which this studies, or you can use both. Before we proceed, we'll look at some concepts. So this is already there in YouTube. There are multiple previous lectures on the same. So looking at some concepts. So one is how can we measure the health outcome? One of the way to measure is QALYs, which is quality adjusted life years. It looks at both the length and the quality of life. For example, in this picture, sorry. Suppose if a person is in 100% of his length, that is his best length, the 100%. So the QALY for 1 year at 100% would be 1. And this is a graph. If you look at as the years go by, if the quality comes down, suppose 40%, so here QALY would be 40% or 0.4. So if you look at this, capture the area in blue, we can capture the length and the quality. And suppose this is 4 years, and based on the quality, we can calculate. So 1 into 0.4 into 0.3 into 0.3. So this would be QALY. We can use it to do analysis. Suppose you have intervention B, which has improved the quality as well as prolonged the life. So you would get a difference in QALY. So this is QALY. How in RCT we look at mortality. This is one of the outcome you can measure to look at quality and length is QALYs. Second, what are the evaluations we can do? So we can either do a cost benefit analysis, minimization analysis, effective analysis, or utility analysis. So when we do a cost effective analysis, this study has looked at cost effective analysis and we'll be looking that in detail. Second is a concept of discounting. So if there is an item today which has a present value, looking at future, suppose 10 years, the value for the same would go up. So if you look at now, we need to discount for the value which now value will be less and 10 years later, 20 years later value will be more. So we have to discount for that factor, and that is called discounting factor. So that is used when there's a long time horizon, a long year. So the concept of discounting. Third is how do you assess? How do you give the assessment? So when we do a cost effectiveness analysis, we can use QALYs, and the way we measure is looking at incremental cost effectiveness ratio. For example, in RCT, we look at relative risk. Here we can look at a ratio which is called as ICER, or incremental cost effectiveness ratio. That is nothing but the difference of cost by the difference of effectiveness. So the lower the ICER, the more cost effective it is. Now going back to the decision analysis. So if you look at decision analysis, what is it? We know that we are faced with multiple complex medical decisions and there's a lot of uncertainty. For example, if there is anticoagulation, which is very good for hospitalized patients in preventing stroke. But if your patient, if the bleeding risk is very high, you will not use it. So we have a lot of uncertainty. For example, we know DAPA or SGLT2 are very good drugs. But if there's a patient who's called recurrent urinary tract infection, you would not use it for that patient. So every day we do this, something of this sort. So we look at risk versus benefit. Usually in terms when there is uncertainty in the best course of action. Lot of times we use intuition, but is there a better way to do it? So this is an analytical method which makes this complex medical decision more reproducible and evidence-based. So what is this? This is a process. This is a systematic process. It looks at a model-based evaluation, and that is what we'll be looking at today. It uses, there are multiple modeling analytic tool. We'll be looking at decision tree and Markov model. So we will understand first what it is and then proceed. Now suppose there is a new blood pressure medication which is developed. Your question is, what is the cost effectiveness of a new blood pressure the medicine compared to placebo? And you want to know at the end of 1 year, what is the probability of a death or a cardiovascular outcome? What can you do? You can do something like this. So you have taken your problem, that is a people with hypertension. You can give them new blood pressure medicines and you can give them a placebo. If you give a new blood pressure medicines, you have possible outcomes. You can have a no cardiovascular disease or a cardiovascular disease or a death. And when you get an outcome, for each outcome you get, you can actually look at the cost and the utility. And when you come at this, suppose you're giving a medicine, you can say what is the probability, like 80% probability of not developing a disease, 15% of developing a cardiovascular disease, and 5% of developing a death. So you get a probability and you get a cost and utility, and you can divide, you can multiply probability and utility, and you get a number in the end of it. So the end of 1 year, for each you will get a value. What is the probability and utility? And based on that, at a glance, visually you can see which might be more cost effective. So if you do a simple thing like that, you get a, we talked about ICER. You get a ICER at end of 1 year, because we are looking at probability at end of 1 year. So you get a visual representation in which you looked at all possible outcomes and you get a value and you know which is more cost effective. This is called decision tree. So how does it start? It starts with the root node where everything begins. You start your question or your problem. Here, people with hypertension. Once you have your root node, then you have the decision node, which is a blue square. Here, you choose a path. So you can choose either to give the medicine or you to give a placebo. Then the circle is called the chance node, where the outcomes happen based on probability. So here, 80% probability of no disease, 15% of cardiovascular disease, and 5% of death. And this triangle is the terminal node, where you have get the final outcome or the result. And these lines are the branches. This is like a tree. You have a root, you have nodes and branches, and you have a terminal leaf node. So this is called a simple decision tree. So in visually, you can see what is more cost effective. So this is a simple decision tree. Now here, you start here and you end here and you see here. Normally you can't come back in a decision tree. But now suppose your question changes. You want to know, yes, I have data for 1 year. End of 1 year, I know what are the probability of death and cardiovascular outcome. But I want to look at what is the lifetime risk or over 30 years. So if you have a time factor, or you know that patients can have multiple outcomes. It's not that they have only one outcome. You can have more than one event over 30 years. Or you know that in a medicine or in a health state, people change their state. They can be healthy, they can be non-healthy. So if you put all that, your model will look something like this. You have patient with hypertension. They can have acute cardiovascular disease, stable, which can transition. You can have a death. You can even have death not related to the cardiovascular disease. So in reality, we get different states. So if you have something like this, different health states, you can use something called the Markov model. So it's called the Markov or a transition model. This is used to show movement between different health states over time. So your probability changes based on what your health state is at that point. So to do that, you can use something called a Markov model. Suppose in the same question, which we looked at before, you want to know what happens in 30 years. So 1 year probability is same. So every 1 year, your probability is same. What happens in 30 years? And you have a cohort of 100 people. What can you do? So you can do something called a Markov cohort modeling. So this is how it looks like. So you start with here, the smiley patient faces are the individuals. So you've got 100 individuals here. This is the years as go by. And the numbers in the circle are the people at the end of each year, and the probability changes according to probability changes from 0 to 1. So these purple lines are the probability from no disease to various other probability. This orange is from cardiovascular to other probabilities. Blue is from death to other probabilities. So you see over every year how it changes. So this is called Markov cohort model. So it gives you ISA, that is the difference between the intervention and control groups over 30 years. You have value for 1 year, but you model for 30 years. And at the end of it, it looks something like this. This is a Markov cohort model. So same decision tree. You start with the root thing, people with hypertension. You have the decision node. You have given the medicine. This circle represents the Markov node. So it has done all the probability and it has given you, these are the 3 decisions you can do. Three decision, this decision you have taken, these are the outcomes. For each outcomes, you get a terminal outcome. This is a terminal triangle leaf with the probabilities. So if you look at here, you have probabilities, and end of it, for a no cardiovascular disease, you will have some utility. So you can multiply it and you get a utility here, here, here. How does it help you? This is called folding back the tree. You start with here. In the end, you will have a utility probability. This is a probability and the utility here. You will get some value. What is the cost for this? You start back from here. So folding back is starting from left to right. So at end of this has happened. Then you can, this is one outcome, second outcome, third outcome. You can sum it up. You'll get a cumulative outcome at each chance nodes. So you know, if you give this medicines, what is the outcome here? What is the outcome here? What is the outcome? And you can take the most cost-effective outcome. So this is called folding back the tree. And at every chance node, you can multiply the probability into utility. And then you get a summation. And then you know for each decision, what is the cost effectiveness. The question is it specific to this Markov model or any decision tree? So the Markov model, this is a cohort model, or in this model, you can go folding back. In the normal decision tree, usually you cannot go back. This has calculated probability over a long time. So you can actually come back and see, it gives you the various options and it gives you over a time. To summarize, decision tree you take for a short-term one-time event. Markov model used for chronic recurrent conditions. You have a horizon, you have repeated risk. So we will be looking at this too. So Markov model, when do you use? If you have a long time horizon or your probabilities change or your health state changes. So you can use a Markov model instead of a simple decision tree. So what is a decision analysis process? So if you are doing a decision analysis, first you design the tree. Then you gather all the information, and in that you can decide if you want to do a Markov model or not. You calculate the cumulative probability, and based on that you do a sensitivity analysis. So this is a process. First most of the study, you start with the PICO process. You do a decision tree, and then you need to know if Markov model should be added. It depends on what is your question. If Markov models are added, you have to use a time horizon. And cost effectiveness, as economic study, you see which provider you want to look at, healthcare or the individual provider. You identify the probability and you get the utilities, and then you fold back the tree and see what is your preferred course of action and how certain you are, you do by doing a sensitivity analysis. So we'll come to the question. So we will look at how they have done a decision analysis in a study. We'll come to the question. Suppose you are advisor to the health minister of Tamil Nadu, and the health minister has heard about a multi-drug resistant TB preventive strategy with a drug called levofloxacin. It heard that if you give levofloxacin, you can reduce the incidence of a multi-drug resistance, incidence of TB in contacts with multi-drug resistance. He asked you if that would be a cost-effective strategy. Now, to answer that question, we will be looking at this study, which is evaluating the cost effectiveness of levofloxacin therapy for household contacts of multi-drug resistant tuberculosis in Vietnam. This is done using a decision analysis. And to critically appraise it, I will use this User's Guide to Medical Decision Analysis, which was published in 2021. Just before we start, just some terminology. So WHO, TB disease, we know people with clinical signs and symptoms. TB infection is no clinical signs and symptom. The old term was latent TB. So TB infection and TB disease we'll be using in this study. So for critical appraisal, we'll go through 3 parts. Are the results valid? What are the results and how do I apply the results to my patient? So this is actually there in the CASP questionnaire, which we are familiar with. To do this study, the first 2 is put in first and second judgment. So we will look at the first judgment. I'll go it in detail. Second judgment, and then we'll look at how is it applicable. The first judgment. The question is, was the methodology of the decision analysis credible? Now, aim of this study was to see how cost effective is 6 months of levofloxacin as compared to placebo when it is given to household contacts of microbiologically proven MDR-TB. Okay. So did the decision analysis address a relevant clinical question? So the clinical question was looking at the cost effectiveness of 6 months of preventive levofloxacin therapy in contacts of MDR or rifampicin resistance TB. Did they have a specific group of patients? So in this study, they have taken a single cohort. The entry age was 40 years. The cohort were household contacts of people with MDR or resistance TB in Vietnam with TB infection. We know Vietnam is a high endemic area. They have included HIV, low BMI, diabetes, and CKD, which we are more interested in. So they had a specific group of patients. Second, was there an actionable intervention or an alternative course? So here the intervention was 6 months of weight-based daily levofloxacin preventive therapy. Alternative was placebo. What are the outcomes used? Was it relevant for clinical decision making? So here the clinical outcome they had taken was TB incidence. What is both MDR versus sensitive TB, mortality and post-TB disability. They had also looked at harms. So they had taken severe adverse effect, grade 3 and 4. So they had not taken the low grade and bothersome effects. They had taken patient important outcomes in QOLIS, which we discussed before, economic outcomes in the terms of cost of drugs, treatment, adverse effects, and post-TB sequelae. So this probably, because of this, is relevant to both patients, clinicians, and policymakers. Now, is a time horizon appropriate? So what is time horizon? It's a time frame of the model. It should be long enough to capture any cost and benefit that occur because of an intervention. If you're looking at, suppose, TB reactivation, so you would want to know a lifetime risk. But if you're looking something like a cancer recurrence, few years might be enough. So it depends on the question, the horizon. In this study, they have taken a decision analytic Markov model. They have taken a 20-year analysis horizon. To remember, they have started entry at 40 years, so they have taken a 20 years. It's actually good enough to capture a long-term progression, but may not give us a lifetime risk. Now, are the variables in the model? So the variables are the probabilities and the utilities based on the current evidence. So the effectiveness is levoflox effective. They had taken based on 2 RCTs. So they had taken a hazard ratio. They had estimated a hazard ratio from Bayesian synthesis of both the trials. So there were 2 trials done. And the hazard ratio they had got was 0.6 and the individual trial was 0.55 and 0.44. So they had got a effectiveness they had proven based on RCT, which is highest evidence at least for us. And probabilities they had taken. So for the transition probabilities for TB incidence, cure rates, adverse effect, they had taken from the RCTs. These are the 2 RCTs which are there. The probabilities for the TB outcome, was it a cure, failure, or death, was taken from the published literature and the programmatic data from the Vietnamese NTP. Utilities, the QALY, the post-TB disease quality QALY was taken from the Vietnamese life tables, published population norms, and international. So they're taken from the global TB data. Cost. So these are the costs how they had calculated. So direct cost had taken from the Vietnamese NTP. The WHO, the treatment cost. So here, they also have a national policy which they get free treatment, but here the treatment cost was taken based on the WHO standards and the studies in South Asian studies. Post-disability cost was based on the published estimates. So most of it was quite certain. Maybe apart from the last thing, most of the cost they have taken is quite certain. And the costs were estimated in 2023 US dollars. Was there any other available current evidence? So there's a systematic review in 2023, which looked at 11 studies, but all of them were cohorts, but done in USA and not a low endemic area. 2025, there was an update to the WHO had done an update systematic review in which they had taken 3 RCTs, out of which these 2 RCTs which they have included, we use levofloxacin. The third RCT had actually used bedaquiline based regimen. So as if now this is the current best evidence which is available. These are the probabilities they have taken. So these are the probabilities which they have estimated. The cure was 0.6 which they had estimated, and these are the outcomes they have done, and this is how they have taken the qualies. And this is a cost parameter. So they had put in US dollars, looking at how it may translate to our setting. So 6 months of levofloxacin for us comes to some in US dollar, it'll come to around 25 US dollars, compared to 42 for them. MDR treatment, so we'd give a bedaquiline based regimen. So in the government, it comes to around, in Indian rupees, it comes to around some 4,000 rupees. But apparently, if you buy in private sector, it comes to 1.15 lakhs. So 4,000 rupees comes to some 400 US dollars, but this will come to around similar, a little more. So most of it are comparable to our setting also. For cost effectiveness analysis, what was the perspective of the analysis? So they had taken the Vietnamese health system perspective. So this was a healthcare or a healthcare systems perspective. They had not included out of pocket cost to TB patients and contacts. So the indirect patient cost is not included. So probably individual patient level, it might not be applicable. And they had calculated as QALY or cost or QALY gained and the ICER. So what is ICER? So this is just to revise. So this is called the cost effectiveness plane. Here you look at the effectiveness, difference in effectiveness. So more effective, less effective. Difference in cost, more cost, less cost. And you get 4 quadrants. So this is probably the best, less costly and more effective. So this is called as dominant. The new treatment is dominant. This is probably the least useful, more costly, less effective. So you would say the new treatment is dominated. Here and here, it depends on what you're willing to trade off. So here it's more costly and more effectiveness. So here it depends on this willing to pay threshold or what is the ICER. So how much cost you are willing to pay to get effectiveness, or here how much effectiveness you are willing to compromise on to get a less cost. So here, so usually below this ICER of willingness to pay threshold is normally acceptable. Above that, you would probably might need to think about it. So this is cost effectiveness plane. And here the willingness to pay threshold was set at US $4,500, which was equal to Vietnamese GDP per capita. Now coming to the second judgment, what is the confidence in the preferred course of action? So confidence, we talked about folding back on the tree. If you remember, you go to the tree and then you each node, you do probability into utility and you get a summation and you can look at it. So for this was a decision analysis tree. So if they had a TB infection, so you can decide either not to give or to give the preventive therapy. So there are six outcomes they have taken: alive and cured, alive and latently infected, developed sensitive TB or MDR TB, post TB disability, death related to either. Similar in 6 months apart from severe adverse events. What they have not really accounted for is, one, I would want to know, because they have given levofloxacin, was there an incidence of extensive drug resistance TB, XDR TB, something we want to know. Second, we know that if they develop MDR also, there's a chance for reinfection. So was there that? There are 2 things they are not accounted for in the tree. But otherwise, they had actually looked at all possible outcome. And this is a Markov model. So you know that it is a health state can vary. And this is the final Markov decision tree. So this is quite, I wanted to show the whole tree at a glance. We can look at it in small steps. So if you start here, so this is where the decision node is. You would have given therapy, no therapy. Now, if you give therapy, these are the possible outcomes which can happen. You can see the Markov node here. So either you can be alive and cured, And here you will know they can either be alive or die of non-TB cause. Second would be alive and latently infected. The outcomes could be either well, MDR, drug sensitive TB, or non-TB cause. Similarly, for each uh, probable outcome, they can have further outcome. So this is the leaf nodes. So I just wanted to show you how they have actually done it quite well, quite extensively. And this is a Markov node, and this is how they have made the Markov decision tree, Markov tree, model tree. So this is a no therapy, no TB preventive therapy. And they've looked at similar 6 things: alive and cured, latent TB, MDR TB, and with each probabilities. And similarly for the second thing, developed TB disability, non-TB cause, die of TB, and each probability in each. So this is what they have finally got. So if you give levoflox preventive therapy, total cause and total effect, no therapy, and the difference and the ICER. So it can vary from 242 to 2893. Okay. We look at, okay, so before we proceed, so this was the ICER they got. We will look at some concepts which we have done before. So one is, this is the cost effectiveness plane, which we already looked at. So this is the ICER. You get a value of ICER. Anything below that, you are probably acceptable. Above that, you may not find a value in it. Second, this is a cost effectiveness acceptability curve. This is from another study. So if you look at this is looked at a different anticoagulation. This is vitamin K. So you can see that it is, so this tells you how much you're willing to pay. 50,000, 1 lakh, 1.5 lakhs. And this tells you what is the cost effectiveness. So, you know, vitamin K is not very expensive and it's quite effective. So the curve would look something like this, just to show how a curve looks. So this is rivaroxaban, apixaban, dabigatran. Which do you think is least cost effective or dominated? Orange rivaroxaban, green or purple? So here, for this much cost you're paying, you will get this much effectiveness. But if you look at here, this much cost you're paying, but you get only this much effectiveness. So which you think is doing worse in the curve? Yeah, dabigatran. So if you look at this purple, this is probably the one which is more dominated. This is just a visual representation, tells you the acceptability curve. Now coming back to our study. So this is the curve here. So this is no treatment. So no effectiveness. Cost is also, this is the cost effectiveness threshold, how much the cost is, and this is the how cost effective it is. So it may not be much effective. Money, obviously you don't have to pay much. And this is the curve for your therapy, which is quite okay. Second, so we saw the plane, which we saw 4 quadrants. So here, this is the 2 quadrants on the left. If you imagine this line, so there'll be 2 other quadrants. If you look at it, most of it is in the lower left quadrant, so which you are happy about. This is dominated. Some of them are in this quadrant, but this is the willingness to pay threshold which they have taken based on per capita GDP in Vietnam. So actually, if you see, most of it is coming within their, under the willingness to pay. So their ICER, based on that, it seems to be very cost effective. So we have got a ICER, and based on that, we know it's cost effective. But how robust are the decision analysis results, or how certain you are? So like how in relative risk we give confidence interval, or how certain you are. So this is tells you how certain you are. So to know how certain you are, you can do a sensitive analysis. Now sensitivity here, they have done both one way and probabilistic sensitivity analysis. What is sensitive analysis? It can be represented in something called a tornado diagram. This x-axis is a main outcome. So here we have looked at difference in QALY, the QALY gained. This is the point estimate, the vertical line. You look at different variables which can affect your ICER or which can affect your primary outcome. The variable which affects, so this width of the bar tells you the variability or the impact. Everything on the right is a net gain. Usually on the left is a net loss. And it is in descending order of size. So the variable which is the most uncertain is on the top. and the one which is on the bottom will probably make the least impact. What you should also watch for things which have opposite effect. That is, it has effect here and here. For example, if you look at the first thing, risk of developing, this is from another study, not from this study. If you're looking at risk of developing active TB, this is varying from here till here. So it can either be positive or a negative. So what you're looking for is whatever is acceptable for you. Does this fall, does the variability fall within that? The most widest is will be on the top. That tells you the most uncertain or the most variable. So if you look at this, yeah, wider, something like a wider confidence interval. But here, if you say the more variability, the more uncertainty it will bring to the study. Coming to our study, so this is that tornado diagram. So this is the incremental cost effectiveness ratio. This is 0. This is what they got, minus 573. This is actually what is the willing to pay threshold for them. If you look at it, the things which has most likely affected, so the red they have put as a negative and blue they have put as positive things. And if you look at the one which is the most, brings the most uncertainty or most variable, that is, it can be from 0 till minus probably 6,000 is on the top, and that is the cost of post-TB lung disease. But still, that is not causing your willingness to pay. Everything else, so this is probably quite a robust result which we have got. The ICER which we have got is probably quite a robust ICER. Okay, so here is, so we have got an ICER which we are quite happy with. But how we are certain that ICER is always there? Is there factors which can affect? So these are the different factors which will affect your final result, which will affect your ICER. So if suppose this was somewhere here, so there is a chance that your ICER will go beyond the willingness to pay. Then you may not be very happy with it. But here looks like however variable it is within our acceptable values.
You have in cost effectiveness two things, cost and effect. Cost of the new treatment, cost of the old treatment, which is on top of the equation. Cost of the new minus cost of old. Bottom of the equation, utility or the cost effect, the cost of one, benefit of one, and the benefit of the other. So there are only four things which can vary. The cost of the new treatment can vary. The cost of the old treatment can vary. The benefit of new treatment may vary. The benefit of old treatment may vary. So when you're doing this sensitivity analysis, you say, okay, within reasonable limits, how much can cost of new treatment vary? How much can cost of old treatment vary? How much can benefit of new treatment vary? How much can benefit of old treatment vary? One-way sensitivity analysis, you move only one of these, each of these you move one at a time, and you look at the two-way or multi-way analysis, you try to move many of these things at the same time and see what happens. Now you say that, okay, Anuka said that this levoflox therapy is cost effective. But what will happen? Which are the things which really can go wrong? Suppose I do it in India. In Vietnam, it seems to be. So what are the things I must look out for? Which of these four components, cost of the new treatment, cost of the old treatment, in the bottom, benefit of new treatment, benefit of old treatment, which of these is the most susceptible to change in another situation? So according to them, the biggest one which you must worry about is post-TB lung disease. If that is the one which actually the red is actually good here, it becomes even more cost effective. So if you're in some place where the cost of post-TB bronchiectasis or restrictive lung disease, if that is the one which is going to determine largely whether the treatment is going to be effective or not. Because if you have severe lung disease after TB, then you're going to be having a lot of cost for those people. And you can save a lot of that cost by giving levoflox and preventing MDR in the first place. So if you must see for your situation, how do I reduce that part? Or if there's something which moves the other way, let's see probability of failure. Suppose the probability of failure, I want to keep it so that it never crosses that 4,500. So if the probability of failure increases in some place, then we may have a trouble. So in that Markov, there is a cost and there's a probability at every node. even the probabilities, you can't vary it from 0 to 100. Within reasonable limit, if you vary the probability, what will happen? So that if in India, if she's going to ask the Tamil Nadu government whether, then they'll be worried about the top 2 or 3 things, because those are the things they'll say, okay, discount rate is almost same everywhere in the world. Cost of levoflox everywhere in the world probably will be the same. Well, the top 2 or 3 things are the ones we'll be worried. Will we get the same thing as what they got in Vietnam, or the assumptions that they made in Vietnam? So this is actually, you will just get some different numbers. They arrange it from the most variable to least variable to look like a tornado. You know, the tornado will have a big ring on top and the smallest ring in the bottom. So you vary this thing to look like a tornado, or you rearrange the picture to look like tornado.
Thank you, sir. So this is a tornado diagram for this study. And they have actually given high effect. What are the estimates they have taken in value in the supplementary reading? Coming to the last part, are the results applicable to my patient? Now, first, is the population similar to my patient? So they had taken Vietnam and we are in India. So this is the WHO TB Global Report 2024. If you look at India, if you look at MDR TB, one who is diagnosed and enrolled on TB program, India is actually more. So we have more incidence of MDR TB. So probably this will be more effective in our setting. And this is actually the 10 country based on they are ranked in order of the size of gap between the number of people enrolled on TB and the best estimate of incidence. And you can look at it, actually India is first among that and Vietnam is the 9th. So we have apparently the more number of people who are, the people diagnosed and very few people who are actually on treatment. So probably if you put it in our setting, it might be more relevant and beneficial. Second, we know that this was done in a high burden of disease. We have more burden. We also have very large number of close household contact. And if you look at the economic status, we have substantial group with low income group. We have more population. They are an upper middle class country as a whole, but we have lot of people with a low income group. And in this study, is it applicable to us? They have taken 40 as a mean age. So this is a study done in South Orissa, in which the mean age of people with MDR was 36, with ranging from 16 to 58. So most likely, whatever they have modeling they have done in the study with 20 years will be quite similar to our setting. Second, is the intervention similar assessment? 6 months of levoflox for us is very feasible and available. We already have a health delivery system. We have a national TB elimination program. It just needs an integration to that. Third, is the outcome important? So their willingness to pay or their threshold was 4,500. India's comes approximately to 2,500, around 2,800. So if you look at that, our willingness to pay might come down, but it might be still acceptable and it might be still cost effectiveness in our setting. So coming to the last question, if you are an advisor and if you want to know, is there a preventive strategy and is it cost effective? I would say that based on this study, this is predominantly dominated. We don't have some information. So like Indian QALY and Indian cost, we don't know about reinfection and XDR rates, which might change the balance. At least XDR rates the cost. But overall, based on this modeling, if we just input this, we might actually be able to make it applicable in our setting. And what extra we need to do for that would be just training the counselors are already there, make sure the supply of levofloxacin is there, monitor for side effects, and just integrate to our system, which is already there. Thank you.